as Steve was just talking about, we spent a considerable amount of time talking about immunotherapy specifically, and the point that Steve was making at the end there was trying to predict who's mostly likely to benefit from immunotherapy using genomics, for example. But we want to turn a little bit now to something that I'm really fascinated by, and it's about using some of these same principles of stem cells as they apply to autoimmune disorders. About 2 to 5% of the world's population has an autoimmune disease, but 20% of Americans, about 50 million Americans, suffer from some sort of autoimmune disease. And my wife, incidentally, is one of them. So it's something that I think about quite a bit. There are about 80 different diseases that fall into this category. Some of the more well-known ones include MS, lupus, rheumatoid arthritis. Essentially what happens is your body's own immune system starts to attack itself when it recognizes healthy cells for some reason as foreign and starts to attack those cells. And it can be very painful, it can be very debilitating, it can completely transform someone's way of life. We don't really understand why women, for example, are so much more likely to develop this, and we don't know why the numbers have been going up in so many places around the world. So to talk about this, please join me in welcoming Dr. Richard Burt. He's the chief of the Division of Immunotherapy at the Northwestern University Feinberg School of Medicine. And two of his patients, Elizabeth Kougentakis and Grace Meehouse. Please warmly welcome them. It's a fascinating area, and this is, again, a little bit different than what we've been talking about. Dr. Burt, welcome. I wonder if you can just set the stage a little bit for us. Tell us what happens in an autoimmune disease and why stem cells might actually be therapeutic or helpful.
Well, thank you, and it's an honor to be here, and I want to thank the Vatican and STEM for Life and Dr. Bossarge for arranging this. And so to answer that question, I have a video, if it's ready to come up. And so the best way, and I'm glad you asked that question, is to look at this from a broader perspective. And that is where I'll start, and then I'll go right into stem cells for autoimmune disease. But the broader perspective of what I'm doing is this question: is it possible to return to a younger, healthier self? And another way of asking that question, a more practical way, is what tool do we have to return to a younger, healthier state, to make ourselves younger? What tool do we have? And you should be able to answer this being here in this meeting, but that tool is stem cells. And that's because stem cells are the primitive cells that gives rise to all the other cells in our body. And we all begin as one cell. But in life, after we're born, even before we're born, each organ system has a stem cell compartment to help regenerate that compartment and to repair it throughout life. The brain has stem cells, and they're in the periventricular area. The muscle has it, and they're called satellite stem cells. The liver has it, they're called oval cells. But the problem is it's hard to get a hold of them or to expand them up or have large numbers of them to be able to use. And if you do expand them, to keep their multipotency so that they can form any organ and any cell in that organ system. And there is an exception, and that's the immune system. And it is very easy, it's very practical to get a hold of tens of millions, hundreds of millions, or more of your immune stem cells, also called the hematopoietic stem cell, from your blood. And because it's so easy to get a hold of those, I can use those, anybody can use them, to really make a new immune system for people with these autoimmune diseases, a new, healthier immune system. And I'll show you, this all began as animal models a long, long time ago, and then eventually went to human trials. And I'll briefly show you some of that data. But before I start, I wanted to go with this quote from Socrates, and that the secret of change is to focus all your energy not on fighting the old, but on building the new. And what's happened in medicine is drugs, immune suppressive drugs in general, even drugs for hypertension, but drugs for autoimmune diseases, they just continue to fight and try to suppress your old immune system. What we're trying to do with the immune stem cell is build a new immune system for you and get you off all medications. And I want to show you if we're successful at that. So I'll begin with two diseases that we transplant a lot. One is multiple sclerosis. And my patients, or patients who have this disease, this particular person, Ann Romney, was not my patient. She's the wife of Mitt Romney, who ran for president of the United States. But she's publicly said she has MS, and the patients have the best description often, and she said multiple sclerosis strips you of the person you are. And I think that's an excellent description of this disease. And down below I show an MRI of the brain, and so that dark line on the outside is the skull, and those big white circles are demyelination, where the myelin is being stripped from the axons. And then eventually, after that happens, the axons die. And it occurs at different parts of the brain at different times, and it's kind of can be very aggressive or slowly progresses over time in different people. And so, let's see if this will go forward to the next slide. There we go. So I wanted to show you how we get a hold of these immune stem cells for all these diseases, including multiple sclerosis, and that is we simply collect them from the blood. And there's one of my patients who said, you know, I can use her picture for this, but she's getting her stem cells collected, and you can see there's a line right here in her neck. We can do it in the antecubital fossa right here if the vein's big enough as well. But it's a simple procedure. It's well tolerated, and there her stem cells are being collected. She's holding the bag that the stem cells are going into. Through a apheresis machine. It's just really a fancy centrifuge. And the other picture I have here are a picture of those stem cells, and that's what they look like. That's what your immune or hematopoietic stem cell looks like, and we've selected and concentrated and purified them for those stem cells that we've collected from the blood. And then here's a patient getting treated after we collect them. It's a different patient. That's one of my nurses. And what we do is we use immune-specific drugs to get rid of your old immune system. It's a very different regimens. We use different combinations in this MS study. It's only 5 days of immune-specific drugs. No more drugs after that. We stop all their MS drugs. And what's important is this is not a transplant for cancer. Yesterday they talked about that. We don't use these cancer drugs, and we don't have that kind of toxicity. And these are your own stem cells. There's no graft versus host disease. So it's much simpler, much less toxic than what they do for cancer. And so we use immune-specific drugs, knock down the bad immune system, virtually remove it, and we put your immune stem cells back in to regenerate a new immune system. It does it quickly. About 8 days after we infuse them, 8 to 12 days. Most people are day 9 or 10, and they're out of the hospital, discharged from the hospital. It goes so well. You know, they can get up, walk around the hospital floor. There's no isolation or anything like that. As you can see, here's a patient getting his, about to get his stem cells infused. And again, the patient gave me permission to do this. Well, again, the devil is always in the details. And what I wanted to bring out, and this tends to excite or annoy my neurology colleagues when I make this statement, but it's a true statement. I got to find a way of making it that induces tolerance, if you will, doesn't get them excited. But the truth is all FDA-approved drugs, and there's many, many out there for MS, they do not, in all the studies, they do not significantly improve neurologic disability or quality of life. They don't. They're beautifully written papers, whether it's New England Journal or Lancet Neurology, but many of them don't even mention quality of life. It's not in the article at all. But they don't improve neurologic disability, so why did the FDA approve them? And they approved them because they slow the rate of progression of the disease. They slow the rate of your decline in neurologic function. That's how they're approved. So what I want to say to you is that this question, does hematopoietic stem cell transplant improve disability and quality of life? If we're giving you back a new, healthier, pre-disease immune system, it should do that, and in fact, it does. And this is a paper we published in Journal of American Medical Association in January of 2015, and I have the reference here if you want to go to it. But these are 150 patients, everybody that we did up to that time at Northwestern with MS who had a transplant. The red line is their neurologic disability, their EDSS when they came to us. The higher the number, it goes from 0 to 10. A normal person, hopefully those of us in this room are at a 0. A 10 means you're dead from neurologic disability. It's all rated by your neurologic disability. So the lower the number, the better. And you can see by 6 months to 5 years afterwards on the blue columns, they're much improved. The median neurologic disability for the whole group is much less. And that has never been seen with any neurologic drug. Again, neurologic drugs slow progression at best. Some of the very recent ones have a 0.14, 0.17 change in the positive positive direction, whereas here we have over a 1-point change in improvement. And that's improvement or progression, depending where you are in the scale, is defined as either a 0.5 or a 1-point change, and we have more than a 1-point change, never seen before in all these patients. The p-values were highly significant, over 10 to the 10th, actually, but JAMA made us cut it at less than 0.001. And when we looked at quality of life, and remember, none of these drugs improve quality of life, and you can see there's a marked improvement in quality of life, and I wish I could had the time to go into that a little bit more, and I don't. So I just have to show that here, for the first time, we've had a treatment that's reversed neurologic disability, improved quality of life. And the relapse rate at 10 years is 10%, 10 to 12%. So 88, 90% of people do not relapse over 5 years, and they're free of all other drugs. These FDA-approved drugs, you just keep giving and giving until they fail or have toxicity, and then you give another one, or they develop progressive disease and you stop giving it. But I said we regenerate a new immune system. So what we did is we collected lymphocytes from patients and we sent it to the NIH, National Institutes of Health, to colleagues there. I didn't do this analysis because you could argue I'd be biased. They're certainly not biased. They did the analysis, and what they found is we did generate a new immune system, and that was published in Journal of Experimental Medicine. There's an editorial on it saying out with the old, in with the new. Again, I don't have time to go into all the immune analysis that they did at the NIH on the samples before and after the transplant. We did generate a new immune system. And when I showed you that improvement in quality of life in 2 earlier slides on the EDSS, I didn't do that. A neurologist not involved in the treatment did that scoring. So that's very important that we have objectivity in our results. And the final thing I want to bring up on MS, if you look at the cost of these FDA-approved drugs, that's just the drug. It's not the physician fees. It's not the infusion cost if it's IV. It's not the MRIs. It's not drug monitoring, and you got to monitor. You got to draw blood samples to monitor these patients. You exclude all that. Just the drug, you're talking $57,000 to $68,000 a year for those drugs. And to prevent relapse, one relapse in one patient with MS in America, it's $80,000. This isn't my data. This is published data in the Annals of Neurology. And the most recent approved drug, Campath or Lemtrada, it's the same drug, different names, it's $156,000 for the drug for 1 year for the first year of treatment. So a transplant will pay for itself within about 15 months, I believe. We've never done the formal analysis, but it makes sense it would, because I know what the cost of transplant is, and it's a one-time procedure and you don't have to keep giving it. So it's a win-win. The patient gets better, it saves money. If you're willing to amortize it over about 15 months, it saves money for private insurance or public health insurance, which is a win-win to save money and help patients. But as Carl Sagan says, extraordinary claims require extraordinary evidence, and we have to do the randomized trial. We are doing it at the University of Uppsala in Sweden, at Northwestern University of Chicago, and at the University of Sheffield in the UK. We've completed 85% of the enrollment. We're almost done, and thank goodness we have, because patients talk on Facebook. Nobody wants a control arm anymore, nobody, and we're going to have, hopefully we'll be able to complete it before we get too much resistance to doing that. But importantly, the evaluating neurologist is blinded in this. The MRI reading will be blinded by an MRI reading center. So we've done all we can to try to get this objectively done. Now, I want to say, does this work in other autoimmune diseases? I wish I had time to talk about it. I don't. I'm very going to quickly say one other that we treat, systemic sclerosis. This was a patient came to us. We get people coming from countries around the world, every state in America. This patient came to us from a western state, and this made her so contracted. It's like a biblical disease that you almost turn to stone and you can't move. And in fact, when she was put on the exam table, if you put her chest down, her legs go up. You put her legs down, her chest comes up. They can't walk, they can't move, they can't toilet themselves. And that's just the skin. The real damage is what's going on inside her organ system. And I want to show you after the transplant how she's doing. And this should play. It was set on automatic. Anyway, I guess it's not going to.
Can you play the video from up there?
It shows her walking around, opening her car and getting in it. In any event, we're running out of time, but this is, she's been that way. We did the transplant 8 years ago, and she's been doing great. And so that kind of gives me the 15 minutes to summarize this, and if we can have the next slide, we'll just forget the video. And that's my home where we do this work in Chicago. Thank you.
Thank you. Just a couple of quick questions, and I'm going to get to Elizabeth and Grace. I really want to hear these stories. But we think about autoimmune disease, you got too much inflammation, you got your immune system's overreacting, you give anti-inflammatories, or you give things to knock down the robustness of the immune system. What you're saying is replace the immune system, out with the old, in with the new. How durable is it? Does the new immune system start to do the same thing that the old immune system did?
Yeah, so the key is to stop inflammation. We use those immune-specific drugs not only to knock down the old immune system, but to stop inflammation. And once you give the stem cells back, that will make these new immune cells in a non-inflammatory environment, they default to tolerance. And that's how that happens. Now, it is possible to break tolerance in the future. I think, 10% relapse over 5 years in MS is an example of that, but that, 90% go 5 years without any medications. They get much better, and they don't have another attack is pretty amazing for that particular disease. Every disease is a little different, how we approach it. The results are a little different, and the details are very important, and how we tweak the regimen is important for each disease. But we probably don't have the scope or time to go into that here.
All right. Elizabeth, let me start with you. Thank you both for being here. Myasthenia gravis, that was your diagnosis, is that right?
Yes.
Can you tell us a little bit about what that is and what you initially experienced, some of your first symptoms?
Well, when it was explained to me, when I was diagnosed, I was 13. So the way, simply put, they explained it that my body was creating too many antibodies, and the way your muscles move is that your brain sends the signals to the muscle to tell it what to do. And since my body created too many, it was blocking the signal. So the signal was weak, causing me to not be able to move properly. The first thing I felt was my friends noticed when I would smile, instead of my cheeks going up, they would go down. It looked like I was either in pain or upset. The second thing I felt was that my eyes would droop and my vision started to blur, and I would see two at once. And that quickly progressed within a month to me collapsing, my arms and my legs giving out. I was having trouble swallowing food. I was aspirating on my own saliva and choking on liquids. And I was quickly admitted into the ICU, where I stayed for 3 months. And after a certain period of time, the hospitals told me that I was taking all the medications they prescribed. I had done plasmapheresis, I believe, over 17 times. And nothing seemed to be working, so they kind of said that I should go home with my parents and wait it out, and there wasn't much left that we could do.
I mean, no other options? Is that what they told you?
They basically suggested mestinon, which is a standard medication for myasthenia gravis. And we had tried removing my thymus gland. The plasmapheresis cleans the blood. That was supposed to help. But there was no improvement. I was just drastically getting worse and worse.
How hard was it to get a diagnosis, first of all?
It was actually pretty simple. The first doctor I saw in Long Island in New York was able to tell me what I had. I think it was our second visit that we went.
And when you had the diagnosis, what was the next part of that conversation? They think this was, at that time, did they think this would be treatable, or how did they lay it out?
At that time, they told me that it's a disease that people can live with if they take mestinon. Worst case, people take some steroids, which I did, I was on, and that I would be able to live with it, and maybe I would feel a little fatigued, maybe my eyes would droop a little bit, but that's... I had gotten much worse than the typical myasthenia patient.
Was this a more virulent form of myasthenia gravis, or?
Yeah, it was pretty severe. No doctors that I had been to had seen it that bad before.
So you're in the hospital for 3 months, you say. You declined pretty quickly over 1 month. You're just 13 years old, and 3 months in the hospital. My understanding is you were on a breathing machine, or you had to have a breathing tube?
Yeah, because I was aspirating, I was kind of drowning myself, as they put it, so they had to trach me, and they had hooked me up to a ventilator for a while to keep me breathing, because since I was not doing very well and my body was giving out, they kept me sedated for a while.
So if you're sedated, then, and at some point your parents actually had to hand pump the bag, is that right, when you were not on the machine?
That was during treatment in Chicago.
Okay, so I'm gonna talk about the treatment specifically and what you experienced, but why was the, I mean, first of all, your parents here?
No, they're working. They couldn't
Okay,
be here.
they're working, all right. But, I mean, I heard this part of your story, it's pretty, is it true? I mean, so were they handbagging you for a period of time?
Yeah, when I was in Chicago doing the treatment, I wasn't, since I was going through the chemotherapy, which normally makes you a little more fatigued, since I was already so weak, it made it difficult for me to breathe on my own. I couldn't be moved out of the room since I was doing chemo to go down to the ICU where they do have those machines. So my parents were using the manual bag to help me when I needed the help.
And how long did this go on?
Chemo was, I believe, 4 days. It's a little blurry for me. I blocked a few things out. But they were, most of the time, they were pumping.
I just found that really extraordinary. I mean, I have kids myself, and I mean, literally, they're pumping air into your lungs and keeping you alive. I mean, holding your life in their hands. I found that really extraordinary. You didn't have great options at some point, and what do you do next? You, your family, you're pretty young still, but how do you go about finding someone like Dr. Burt?
Well, my dad had actually, he had kept searching the internet, hoping to find any other option. We had gone, pretty far in looking for new treatments. He kind of fell upon Dr. Burt and reached out to the hospital, and luckily they showed interest that they would consider treating me. And because I was young, I had to go through FDA approval because I was 15 at the time, and it's a clinical trial. So he had ended up finding him through the internet, and he spoke with Dr. Burt a little bit, and they decided that I didn't have much else to lose, and this was my best hope, my best option.
Dr. Burt outlined some of the treatment and what it looks like, but what did it feel like for you? Can you recall what you experienced?
I remember the chemotherapy. I remember, well, first we drew the blood to collect the stem cells. That actually took a shorter period of time than you would think, and that was a pretty simple process. Once we started the chemotherapy, that was a little bit tougher for me personally, because like I said, I was weak already. So I kind of just, I was weak to the point where all I did was lay in bed as it was. I was pretty much a vegetable at this point. So, going through the chemotherapy, it didn't change my life that much at that point. I was still laying, I just had a little bit more difficulty breathing. By the time we finished with the chemotherapy, the treatment was as simple as one bag just being put right back through. It didn't take very long, and I don't know if it was the treatment and my hope that I was going to get better, but I immediately felt almost a surge of energy coursing through. The first thing I did was my eyes opened up wide, which I wasn't able to do in over 2 years, and I pointed at a bag of Cheetos that my parents had in the room, and I couldn't speak at the time. I couldn't speak for the 2 years, so I pointed. They brought one over to me, and I guess they felt okay because it also dissolves a little bit, that kind of a Cheeto. So I put it in my mouth, and I was able to chew it. For the first time I was able to chew something in 2 years, and I swallowed it immediately.
You say this, you get the impact of the treatment very quickly. I mean, how quickly are we talking about?
Like, as it was coming through, I almost felt like I felt energy.
Does that surprise you that fast?
Let me kind of expand on that picture so you understand. when Elizabeth came to us, she had already been trached. She came to the CSN clinic with a tracheostomy and had a feeding tube. So she had to be fed by that feeding tube and couldn't eat. And that's why she said for 2 years, and now to be able to get a Cheeto in the room after the procedure. But not just a feeding tube and a trach, despite a thymectomy and plasmapheresis and IVIG and Mestinon and the standard treatments. She couldn't lift her arms up like this. She was so weak that she couldn't lift her arms. Her head drooped like this. She couldn't lift it up. So, you know, this is obviously a very tough place to start a procedure like what we do. And the parents, she has just the most caring, giving, attentive parents, and they'd been used to using an ambu bag on her because of the trach to clear secretions so she wouldn't gag in her own secretions. So they asked if they could, because they're used to doing that, getting up at night using an ambu bag on the tracheostomy to clear the secretions, and they asked if they could continue to do that while she's in the room. Which we allowed because it's not our standard procedure that you know, parents do that. It's handled by our nursing staff. But they had taken care of her for 2 years and were very used to doing this. And so we work with them and them being engaged helped them in this process too. They were used to taking care of her and weren't ready to step back and let someone else do everything. And we completely trusted them. Her parents were phenomenal at this, helping provide care for her.
Grace, before I get to you, let me just ask Elizabeth one more question. Are you doing well now? I mean, you look great. How are you feeling?
Ever since the treatment, I haven't taken any medications. There's no sign of my disease. I live a completely normal life, and I'm pretty strong for my age.
One treatment?
Just once, yeah.
And how many years ago now was it?
It'll be 10 years in November.
Incredible. Wow. Yeah. Incredible. Grace, I rode on the bus with your dad yesterday, so I already got the scoop on you. You had all kinds of questions. Dr. Burt showed an image of someone with systemic sclerosis in his presentation, and that is your diagnosis as well. Is that right? We only saw the picture. Can you tell us a little bit about what it is and what you were experiencing?
Yeah, absolutely. So scleroderma literally means hard skin. And basically what it is, it's an autoimmune disease that affects the skin and as well as the internal organs. And as Dr. Burt mentioned, it's like your body is turning into stone. And that's basically, to explain it simply, there's an overproduction of collagen that's happening. So my immune system is attacking itself, so it's creating inflammation. And that inflammation is causing an overproduction of collagen. That's why my skin becomes very tight, especially in the fingers and in the face. And actually, scleroderma affects about 100,000 people nationwide, and so you can call it rare, but I do believe that there are many cases out there. So yeah.
So what do they do for you initially when you start having these symptoms?
Okay.
Treatment-wise.
Treatment-wise, yeah. They, for medication, it's immunosuppressants. Also, there's I forgot the name of the drug. It starts with an M, Dr. Burr. For the lungs, since the disease, it affects the internal organs. Just a lot of really strong drugs, and also, I believe, steroids to take away the pain of the skin becoming tighter. So yeah.
So the drug with M is really, it's called Celcept,
Yes.
mycophenolate mofetil.
Yeah.
Yes.
Mm-hmm.
And again, you may have mentioned this. How old were you when you first?
I was 17.
17.
When I was diagnosed with scleroderma, and I was actually convinced that I had lupus, and so I took a blood test to see if it was lupus, but it came out negative, so I was very confused. And so I was able to go to UCSF in San Francisco, which is about an hour from where I live. And I saw a rheumatologist, and I told her my symptoms, and she immediately knew that I had scleroderma. And I had no idea at that time what scleroderma was, but it was relieving to have this diagnosis, so I knew what I should do next. And so from there, I was able to treat it and get my own rheumatologist and learn more about it. Then kind of going into my story, I was down in San Diego for school, and that is where I got in touch with a woman who is part of a scleroderma support group down there. And I was able to meet a woman who had just had the transplant with Dr. Burt, and she was telling me about it. And that's how I knew about the transplant. And
So
yeah.
were you getting, were the medications that you were being given, were they working for you, or?
Yeah, so they actually were not. I was on Celcept, and it made me very fatigued, and so I was limited. You know, I was also in school at the time, so it was hard to focus as well. Yeah.
So, you know, you heard Elizabeth's story in terms of how quickly she had improvement. I mean, even literally as it's being transfused in. How about you? How did you, how quickly did you feel some improvement
Improvements?
after?
Oh, yeah, absolutely. I believe so a couple of days after I got my stem cells back, I immediately noticed that my skin loosened, especially my fingers, and actually Dr. Burt noticed that as well. And I wanted to tell a funny story about that. So before my transplant, I saw my rheumatologist because I was she was helping me treat a digital ulcer that I had. And so she told me, you know, Grace, since you have scleroderma, you're never gonna get wrinkles. You'll never have to worry about that because the skin becomes so tight. So you'll never need Botox. You'll never need any of that. And so when I went home that day, I noticed that I didn't have any, you know, like smile lines or anything like that. So I was like, oh, she's right. So actually, so after transplant, I see now whenever I smile, I have smile lines. I've got them up here as well, near my eyes, and so I've yet to prove her wrong. So that was a kind of funny story about that. But definitely the energy, my energy has improved, and the skin, and also my lungs as well. I was before transplant, I was very active, but I noticed I had shortness of breath when I would run long distances, and that was very strange to me. But now, since post-transplant, I'm able to have more endurance when I'm doing any kind of exercise.
The lines tell a good story, by the way. They
yeah,
do.
yeah.
Just ask Dr. Burt and I. How long ago was your treatment night?
So I received the stem cell transplant last July, so July of 2015. So.
And you look great? You feel
yeah,
great?
Everyone says they love my haircut, and I tell them, well, chemotherapy looks good on me.
Well, congratulations. I'm glad you're doing so well.
Yeah.
We only have a little bit of time left, but Dr. Burt, you know, you sort of alluded to this in your presentation. Where are we going with this? First of all, is it being accepted within various communities, the rheumatology community, the neurology community, or how are they looking at this, and where are we headed?
You know, so everybody talks about translational research and abilities to cut across departments and divisions, which is what we have done. But I've learned why that's so inherently difficult to do. And the people within those traditional fields don't have the experience or technology for what we do. And I think that generates more skepticism than they would get from regular pharmacologic drugs that they themselves could give. But, you know, our results and our data are starting now, I think, to have that impact. Certainly in especially some of these diseases, systemic sclerosis was mentioned about the tightening of the skin and people found that humorous, and the fact that it's the only disease you want to get wrinkles in. But the problem is not only does your skin get tight and then you get contractures and you can't move your joints at all, can't even walk, but the internal organs get tight, especially the heart. Tight skin means a tight ventricle, and we've got cardiac MRI data to show that. We need to get that published, and that tight ventricle has no diastolic relaxation. They can tolerate no stress whatsoever. That's why they're getting short of breath. It destroys the lungs too. NSIP, UIP, you know, very inflammatory attack on the lungs, but the number one cause of death in these patients is the heart, and 6% per year die, and 90% of these people are young women. And that 6% per year mortality continues every year. It doesn't plateau off. And there's a recent study out of Europe published a year ago where they showed that still 6% mortality per year every year. And that's as bad, if not worse, than a lot of cancers. So this is really a terrible disease. And we've been able to show in our 2 Lancet publications that we reverse the skin. The skin gets much better, and her skin, from our experience, will keep getting better. It reaches maximum improvement about 2 years after the procedure, and the lungs get better. The forced vital capacity, DLCO, corrected for hemoglobin, these improve. Nothing else has been shown to do that, absolutely nothing else, and they're on no other therapy. And it turns out what we've seen when we look at our data going 5 years out, and we published that in Lancet, is 78% at 5 years have not relapsed, about 22% relapse. So we've still got to try to perfect this better, but 78% don't. But each of these diseases, and what we've learned, because this technology can give fundamentally great results, but it's potentially dangerous. And I think that's one of the skepticisms we meet from people in these other fields who are more risk adverse, is the potential danger of this. And so you really have to learn these diseases, and this therapy helps us understand these diseases much better. It exposes the pathophysiology in a way no standard drug does. For instance, I learned the main problem in this disease is the heart. And I didn't know that. In all honesty, experts in the field don't know that. But it is the heart, and we learned that from our treatment, and we learned how to select people so if the heart is too bad, we won't take them through the procedure because we don't want any mortality. And in our first 90 patients, we had these phenomenal results in systemic sclerosis, but we had 5.5% mortality. 5 of 90 died, and we don't want anybody to die, but the mortality from that disease is 6% per year every year, and the mortality stopped, after our procedure. So that is success, but it's, when you sit at the bedside of each of these patients, spend 3 weeks with them in the hospital, that's a very hard thing to go through. So we figured it out, and we figured out how to test the heart with cardiac cath, with fluid challenge, with echoes, with TAPSE, and with cardiac MRI, so we know who we can't take to this. Then what we found is patients still wanted it. Even though I say, no, I don't think you'll make it through, they would get mad because they don't have anything else that works, and they're only getting worse, and they know what the future holds for them. And so now, more recently, we've designed a very cardiac safe approach to this, where we think we can do it, hopefully get the same results, but have very low stress on the heart. And now we've done 6 patients that way who I know wouldn't have survived the old way, and they all went through very well. And hopefully, it's only 6, but now we may have a method for these hearts that are so severely affected by this disease. Now, something like that you don't see in myasthenia gravis, you don't see it in MS. Their hearts are normal, and we don't have that worry at all. And in a sense, the MS are much simpler transplants than systemic sclerosis for that reason, and much less risky. But I could go on about each disease where we've learned this, but it's you have to have a center experience devoted to this, and you have to tailor what you do, for your disease and for your patient.
Thank you very, very much. Grace and Elizabeth, you're both so well spoken, and I'm glad you're doing well. Dr. Burt, thank you. Please give them a warm round of applause. Thank you.